Good morning, attendees, guests, and speakers, and welcome to the inaugural Jonas Nursing Veterans Healthcare Conference. I am Dr. Stephen Ferrara, Interim Executive Director at Jonas Nursing and Veterans Healthcare, a program housed at Columbia University's School of Nursing and a signature program of Jonas Philanthropies. Started nearly 15 years ago by our founders, Donald Jonas and his late wife, Barbara, we have been the fortunate beneficiaries of their generosity and philanthropy. Their vision to address the nursing faculty shortage allowed them to focus their support on nurse leaders who are pursuing their doctoral degree in nursing. By providing nurse scholars with financial support, Jonas Nursing has been able to provide over $25 million to more than 1,200 doctoral nursing students since its inception. In recognition of all the Jonas family has done to support nursing since then, and in recognition of Donald Jonas's 91st birthday, which is today, please enjoy this brief video.
Barbara and I have devoted many years to the field of nursing. We started with only 6 scholars. Today, it's way over 1,000. We're in 50 states, and we're so proud that we have a special relationship with the nurses and our ally to the nurses, which is the military. We really get such joy out of doing something that's good. I met Barbara, and I was invited to go to a dance at Sarah Lawrence, where Barbara Raubvogel was a sophomore. And that was the beginning. And we got married maybe 4 months, 5 months later. There's no question about it. Marrying and meeting Barbara has been the #1 great decision in my life. And Barbara was with me all the way.
Barbara and Donald Jonas founded Jonas Philanthropies in 2006. Since then, it has become the leading philanthropic organization dedicated to improving nursing and veterans healthcare by advancing the nursing profession and addressing challenges in low vision and blindness and children's environmental health.
They decided that they wanted a field that really needed them, where they could make a difference. And by some quirk of chance, the greatest luck in the world, they decided on nursing.
As the largest segment of the healthcare workforce, America's 3 million nurses are the key to transforming healthcare, increasing access, guaranteeing safety and quality, and lowering costs.
We've dedicated ourselves using the tool of education.
We are flooded with applicants for every nursing program in the country, be they state, private, it doesn't really matter. Students want to go into nursing. We simply don't have the faculty to support them.
Being a Jonas Nurse Scholar is very special. It means that we're with you. We're all the way.
My main focus is the health of migrant populations.
My research interest is in workforce development, particularly enhancing the role of nurses in sub-Saharan Africa as well as Asia.
Everybody needs nursing, and always will. The nurses are the backbone of our health system. I love what I do, and that's why I'm doing it, and I honestly believe we've made a difference with our nursing and veteran health care plans. Nurses will always be my #1 cause because they need us. And it's the highlight of my life to be productive and do something in the nursing world. We want to continue to do some extraordinary things, to be the nurse leaders of the future. My goal is to do the right thing for people.
Thank you, Donald and Barbara, for your inspirational vision, and happy birthday to you, Donald. The Jonas philanthropy legacy continues to be carried out by family members John Jonas and Lendry Purcell, overseeing our commitment to vision, environmental, and climate health, as well as the nursing and veterans healthcare focus. Together, they lead the Jonas Philanthropies Advisory Board and the organization's ongoing commitment to serving the nation's most vulnerable communities. The World Health Organization declared 2020 as the year of the nurse. Little did they know what nurses were soon to face. The COVID-19 virus has swept the world and has shown us that it truly has been the year that nurses are some of the most essential, dedicated, frontline healthcare workers. Today's conference is a response to the compassionate care that we know our VA facilities provide to our nation's veterans. We know that since the passage of the Mission Act in 2019, many veterans may be seeking their healthcare outside of traditional VA settings. We recognize that veterans have unique healthcare needs and that private care healthcare clinicians who may not typically see veterans in their practice may now be seeing them more frequently. We will address some of those knowledge gaps today. Thanks to our speakers and our subject matter experts, we will share research and practice findings to help the nursing workforce. Columbia University School of Nursing is accredited as a provider of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive credits for participating in today's conference, an email will be sent to you next week with instructions to complete that process. Please be sure to follow us on social media and tag us on your conference post with the hashtag JonasImpact. Today, we will be using the platform Slido, which allows you to submit questions for our presenters through the Q&A tab during each presentation. Please note that there will also be several interactive polls throughout the day's presentations, so please be sure to participate. To kick things off, I am pleased to welcome Derek Coy, Veterans Health Program Officer at the New York State Health Foundation. We thank New York State Health Foundation for their support in helping us reach our conference goals and recognizing the importance of the unique healthcare needs of our veterans. Derek will now share with us some of their research and help set the stage for our conference today. Welcome, Derek.
Thank you so much for having me. I really appreciate that. I'd like to first start things off by thanking Jonas Philanthropies for their amazing work over the years, especially their nursing and veterans healthcare program for putting this virtual conference together under such trying conditions. And a special shout out to Mary Fiore for the amazing work she's done to make this happen. Really appreciate that. Also, like to thank all the panelists, a really great lineup of folks will be speaking later. So I'm excited to stay tuned for that. And lastly, but certainly most importantly, I'd like to thank you all that are in attendance for not only logging on today, but for your dedication to this work, especially during these challenging times that we are all experiencing. Things have been pretty tough lately, to say the least, but seeing this many folks committed to such an incredibly important topic is one of the few bright spots in one of the worst years in modern memory. So thank you all again for that. As Dr. Farrar mentioned earlier, my name is Derek Coy, and I'm a former Marine Sergeant and Iraq War veteran, and I currently serve as the Veterans Health Officer at the New York State Health Foundation. We decided to kick things off today by setting the stage for a larger discussion about the unique healthcare needs in the veteran community that you all will be hearing more about throughout the day, in addition to providing some insight into specific health issues veterans in New York State face, according to some research that we at the New York State Health Foundation have helped support. So I'd like to dive right in. The two main things I want to discuss with you all today will be one, how the private healthcare community can ensure quality care for vets seeking care outside of VA, and two, to help identify gaps in private care veterans may experience. Before we dive into those two topics, though, I think it's first important to understand why there's a need for the private sector to understand these issues, as well as understanding the potential opportunities these provide. So to start, where do veterans receive healthcare and what are their health needs? We're going to start with the former question first. Most assume that all vets have access to VA when they are discharged, and this is definitely not the case. Due to eligibility criteria, personal factors, only about half of the approximately 20 million veterans in our country are even eligible for VA healthcare. So when you take that down to about the 9 million or so that are eligible, only about 2/3 of those will actually use VA on any given year. And that's according to the most recent numbers in 2017. So of those that do, because of recent laws like Veterans Choice Act that was passed in 2014 and the Mission Act passed last year, there's about a 1 in 3 chance that if you go to VA will actually refer you back to the community for your care. This is up from about 1 in 4 appointments being purchased in the private sector from just a few years ago. So again, clearly in response to these new laws, veterans were already using a lot of VA care for the, a lot of private care for the most part, and are even doing so more so now. So why do veterans choose private care over VA? That's a question that we at the foundation had actually wondered when we first kicked off our veterans work a little over 10 years ago. And according to research from the RAND Corporation and needs assessment that we commissioned, it's mostly for practical reasons that we all use. For instance, the provider is closer to home, it's already where your family's receiving care, or they feel more comfortable in a community provider. To give an example, I actually live a stone's throw away from the Bronx VA. I can actually see it from my apartment now, but I also work super close to the Manhattan VA, in addition to having great private insurance, which I'm very appreciative of. So it depends on what my needs are at the time. And this is true for a lot of veterans that are eligible even for VA healthcare. For instance, if it's something related to my traumatic brain injury, I usually go to VA, but I've also been seeing a private therapist through the Headstrong Project for the past 7 years. My private provider is also right around the corner from my office. So these are all options that I have at my disposal, and it just depends on which one makes most sense for me. So once this is understood, it's pretty clear that for the most part, when we're talking about veterans healthcare, we're talking about healthcare in the private sector, because that's where most veterans will access it. So back to the original 2 questions, how can we ensure quality in the private sector and how can we identify gaps? We'll start off with that first question. Despite the majority of veterans seeking care outside of VA, VA has been the gold standard for providing high quality care to veterans for the last generation or so of warfighters. I know this may come as a shock to most folks who understandably still view VA from the Ron Kovic born on the 4th of July perspective, because there was a lot of truth to that historically, but things have drastically changed at VA over the past 20 years or so. Starting with Kenneth Kaiser during the Clinton administration, VA has objectively provided care that is at least on par with private sector care and oftentimes of higher quality. It's also less expensive than the private sector, much less expensive. And even things like average wait times for primary or specialty care are less than the private sector. So for instance, it takes about 21 days to get a primary care appointment at VA, which certainly isn't optimal. It's a long time to wait, all things considered, but compared to the private sector is about 28. So in addition to that, VA has also been an innovator in coordinating care. It continues to build on its legacy of investing in research that expands beyond the veteran community. You could look back at a long history of things like the development of the pacemaker, the nicotine patch, electronic health record at VA, and realize it's really had a lasting impact outside of the space. And something that I'm sure many of you all already know, VA trains the majority of doctors and nurses across the country through residency programs, and is also a research powerhouse. So it's really a model that's worth replicating. I'm clearly a huge cheerleader for VA, and I love what it's been able to do throughout the year. So I'll openly admit my bias. However, I don't want to act like VA is perfect by any means, because that's certainly not the case. So to answer that first question, I think one of the best ways to ensure quality care is replicating what VA does well and understanding what VA does poorly, so that we can avoid replicating the bad parts and can invest in doing what VA does well. So looking at what VA does well, that's worth replicating, I would say because its development of coordinating care and the electronic health record, once you're into VA healthcare, your care is pretty seamless. You can have all your care at the Bronx VA, but if you decide to move to Illinois, it's pretty seamless in that transition. This is perhaps obviously pretty hard to replicate in the private sector, but what it points out is how difficult fragmented care can be. VA, of course, provides healthcare, but it also screens for food insecurity. It has workforce development programs and does things like art and music therapy and can assist with housing and legal aid as well. Again, oftentimes these are almost impossible for providers to replicate in a smaller community or private setting. However, what I recommend is tapping into networks like IAVA's Quick Reaction Force, the New York City Veterans Alliance's Case Management Program, or the Vet Connect platform here in New York City. There are quite a few one-stops and veteran outreach centers across the state and country. So I recommend tapping into those because you may not be able to provide these services in-house like a lot of folks wouldn't be able to. But if you're able to make a warm handoff to a community provider that can pick up that slack, you can come close to addressing the additional social determinants of health that impact veterans' well-being. And one last thing for now, what that VA does well, and is more or less by default, is understand that they're serving veterans. Because 99% of the time, if you're accessing care at a VA healthcare facility, you likely served in the military. I often ask private sector healthcare providers if they know how many veterans they serve. If so, what area did those veterans serve in, and what health issues are they seeking care for? And this is pretty hard to capture if providers they don't know if they're serving veterans because they're not asking if they served. So for all the aforementioned reasons that lead to an increase in veterans using private sector care over the last few years, we at the foundation wanted to know that if private providers actually have the capacity to provide high quality, culturally competent care to veterans in New York State. So we reached back out to our friends at the RAND Corporation 2 years ago to study this in New York. You can check out the entire report authored by Terry Tennelly entitled Ready or Not, but in short, they aren't. Only about 2% of private providers meet the criteria for providing high quality, culturally competent care to veterans. And this isn't super surprising, but it also answers our second big question: where are there gaps in services in the private sector? So let's dig into why this is the case. To start, most folks don't even screen for veteran status, which in itself can be pretty tricky because even asking, are you a veteran, turns out to be pretty subjective. If the veteran doesn't identify as such, or maybe they define it differently, maybe I served, but I didn't deploy, maybe I deployed, but I didn't see combat, they might not feel like they're a veteran. That said, it's hard to address the needs of a population when you don't know that someone belongs to that population. So increasing screening practices is a great way to identify these gaps. And most agree asking, did you ever serve in the military, is usually a great way to start. Secondly, despite screening being incredibly important, what is equally so is understanding what that could imply. According to Ready or Not report, most private providers aren't familiar with military culture or the health issues that are associated with serving in the military, which is incredibly problematic. This brings up the last thing I want to harp on, and was glad to see will be addressed throughout the remainder of the conference, which is what are the unique health needs of veterans? We can sometimes assume that most veterans are straight white men that are predominantly from the South, which it does have some merit behind it statistically and historically speaking. And I would highly recommend reading some of what Kayla Williams has written about diversity in the military community to learn more. But the big takeaway is the veteran community is not a monolith. It's incredibly diverse. So we can't speak for all veterans, but what we can do is explain some unique challenges that we are seeing in the community. For instance, looking back on some of the things VA does not so well is provide a safe environment for far too many women veterans. Again, this fluctuates between facilities, but on the whole, about 1 in 4 women veterans experience sexual harassment or assault at a VA campus. This is problematic for myriad reasons, but it is important to understand considering women are the fastest growing demographic in the veteran community. In addition, most doctors wouldn't recommend a woman be screened for breast cancer before the age of 40. However, considering the disproportionately high rates of cancer in women veterans, doing so can be life-saving. Again, if you're screening and you understand that you're serving a veteran. But this can't be done if A, you don't know the woman you're treating as a veteran, and B, you are unaware of some of the unique health needs of women veterans in particular. Exposure to hazardous material and waste has widespread health implications for countless veterans. And I would highly recommend reading more about this and the great work of the TAPS organization from a McClatchy piece authored by Tara Kopp to learn more. But these aren't unique per se to the veteran community, these issues at least. The reason I say that is that we can look at water in Flint or Newark, or air quality in the Bronx or Bakersfield, and it's clear these issues impact us all. What is unique, however, is how disproportionately veterans are impacted by environmental health hazards. A similar comparison can be made in regards to one of the worst issues veterans currently face, which is the continuously growing suicide epidemic. Depending on how you count and define the term veterans, approximately 17 to 20 die by suicide every day. Even some of the units hit hardest by casualties during our forever wars have now lost more members to suicide than to combat. And this is certainly true for myself. But this is not a veteran issue. It's an American issue that disproportionately affects the veteran community. Suicide rates for the general population have continued to rise over the past 2 decades across the country, and the age-adjusted rates are the highest they've been since 1941. So to point out my last gap in services provided to veterans in the private sector, I would have to focus on an inadequacy across the board regarding how we discuss suicide and some of its largest contributing factors, such as firearms. More than 60% of all firearm-related deaths in 2018 were suicides, and about half of those suicides involved a firearm. For veterans who have a higher rate of gun ownership, it's nearly 70%. Again, because the veteran community is made up of Americans, the issues we face are reflective of larger issues our civilian counterparts face, but it's usually at disproportionately higher rates. Trauma is not exclusive to the veteran community, but does affect veterans disproportionately. So to sum up a few of the things that I've covered, how best can providers ensure that they are delivering high quality care to veterans? I recommend replicating what VA does well while avoiding what it doesn't do so well. So increased screening and gaining a thorough understanding of the issues veterans face is a great start. And I highly recommend learning more about trainings that can help, such as one developed by Dr. Joe Geraci at Teachers College, which I'm happy to share more info about that. They're a grantee of ours, so definitely biased there. And learning more about the diversity within the veteran community and how it impacts health outcomes, which again, I would defer to the amazing Kayla Williams for that, which you'll be hearing more from later today. Also, increasing your ability to provide the wraparound services in conjunction with the local case management provider is incredibly crucial. Again, you probably can't do those things on your own, but if you can rely on other folks in the community to do it, you're replicating something that VA does extremely well. And also, I recommend avoiding what VA doesn't do so well, which one example would be provide a safe environment for all of its patients, whether they're women, minorities, or members of the LGBTQ community. I think by doing this, private providers will be more in tune with what the needs of the veteran community are, while also being able to identify gaps with their own services, which will help increase the quality of care veterans receive in the private sector. And my last recommendation is to lean on folks like Terry Tennelian and Tara Kopp that work incredibly hard to put this information out there. In our Ready or Not report, more than 2/3 of clinicians reported not even knowing about programs that have resulted from choice, let alone the problems that have been associated with its rollout. So we know that the overwhelming majority of veterans are seeking care in the private sector, and I think that speaks volumes. So if we know where they're at, I think it's on us to increase our quality, make sure that we're more accessible, and I really look forward to continuing that work with you all today.
Thank you, Derek, for that great presentation. We did get a question, and the question is about the RAND report that you mentioned regarding community readiness to care for veterans. Could you perhaps provide a link to that, and then we could share that with all of the attendees?
Absolutely, I'd love that. I'll send it over right now.
Great, that would be fantastic. So again, thank you, Derek, as well as to the New York State Health Foundation for continuing to make the care of veterans a priority. We now turn to our next segment, Understanding Military Culture. I am pleased to welcome Dr. Yuval Neria, Director of the PTSD Research and Treatment Program of the New York State Psychiatric Institute, and Dr. Alicia Gill Rossiter, a retired Lieutenant Colonel of the United States Air Force Reserve's Nursing Corps, and currently serves as the military liaison and the director of the Veteran to Bachelor of Science Nursing program at the University of South Florida's College of Nursing. I am happy to point out that Dr. Rossiter was herself a recipient of a Jonas Scholarship when she pursued her doctorate and is a leading member of our Jonas Scholar Alumni Network. Welcome, Drs. Neria and Rossiter. Why don't we start with you, Dr. Neria?
Sure. Good morning, everybody. Very excited to be here with you and to share my views about veterans' mental health. I have military experience myself, previously a veteran of the IDF who came to New York City after 9/11 to put together a trauma program at the New York State Psychiatric Institute in Columbia University Department of Psychiatry, where I currently direct the Military Family Wellness Center that provides evidence-based treatment for veterans and their family members, especially veterans who are either reluctant to seek care at the VA or are not eligible to go to the VA and receive care, and family members, as you all know, are an essential part in veteran mental health. And just to complete a little bit about background, at my center, we are especially interested to both to study the mental health implications of COVID-19 among the veterans community, as well as to treat veterans instead of stopping seeing veterans face to face. We completely transitioned to online, HIPAA consistent and secured mental health delivery over the internet for everything that we are actually doing, and we have seen a lot of kind of emerging issues among the veterans community. People who have been recovered from PTSD suddenly relapse, showing more anxiety, more depression. We see family members who are very worried about their loved ones. So I think this conference is timely, and I'm happy to share more about our work later on.
Thank you, Dr. Neria. Dr. Rossiter?
Good morning, everyone. I'm happy to be here today. I'm thrilled that the Jonas Philanthropies is hosting this very important and timely webinar on veteran healthcare. So thank you. Obviously, this is a topic that's very important to me as a veteran myself. Back in 2011, I transitioned out of practice and into academia. I became a faculty member at the University of South Florida. And this is about the time frame when the Joining Forces initiative was launched with the during the Obama-Biden presidency. And we really started focusing on, looking at the healthcare needs of veterans and how to identify them and how to engage them in the healthcare arena. At that time, the American Association of Colleges of Nursing joined forces, as did numerous other healthcare professions and other organizations in the communities, really focusing on improving health outcomes for veterans. So I think I was kind of in the right place at the right time in regards to, veteran healthcare. The University of South Florida, we were able to develop a course for our nursing students, really looking at the impact of cultural competence and why this is important. Why is it important to identify these veterans? What do we need to know to provide culturally competent care to ensure that, once again, like I said, that they are receiving obtaining health outcomes that are appropriate for their needs. We've come a long way over the past, 10 years in regards to incorporating cultural competency and veteran competencies into academia. Not only did we have a course, there's other programs now across the country that are utilizing these competencies and integrating them into their nursing programs from undergrad to graduate. But we have a long way to go. And we know now with the Mission Act, we will be seeing more and more veterans entering the civilian sector.
Thank you, Dr. Rossiter. So I have some questions that I'd like to pose. I'm going to ask Dr. Neria first, and I remind the audience that if you have any questions for both Dr. Neria and Dr. Rossiter, to type them in, and please direct them to which presenter you'd like to address it to. So Dr. Neria, do you think COVID-19 poses special risk for veterans' mental health, and why?
Yeah, I do think so. The COVID-19 pandemic is a condition that actually nobody has to. It's a global threat with great scope and magnitude. Actually, that is hard even to estimate in terms of its effect on mental health. And there is data already coming from the US, Europe, and China and other places showing that there is a significant increase in risk of mental health in the general population, especially among high-risk groups such as healthcare workers, first responders, people who lost loved ones, etc. With regard to veterans, I believe that veterans are at a unique situation. They have, as we all know, kind of high risk for a number of mental health problems as compared to the general population. Increased risk for PTSD, depression, suicidality, substance abuse, and those are the things that we are seeing all the time. And people who are prone to psychological problems are especially vulnerable during COVID. COVID is interact with COVID risk for mental health problems, interact with the pre-COVID risk to, and veterans face a number of problems. We already see veterans as more vulnerable in the population. They have almost double the rate of anxiety as compared to the general population, regardless of COVID, and high risk for depression, etc. But what we can sense through our pilot studies and treatment center is that the risk is becoming greater, and I am afraid that the current services, because of the shutdown and the difficulty to maintain face-to-face treatment, the access to care as delivered by the state is highly limited, and I am really concerned about availability of mental health treatment, how important mental health treatment are, etc., etc.
Thank you. And along the same lines with mental health, why do veterans in particular with mental health problems avoid seeking mental health care?
Well, this is a question for me.
Yes, I'm sorry, Dr. Neri. Yes, well, so
No.
why do veterans with mental health problems avoid seeking mental health care?
Yeah, so I think veterans have a kind of unique set of barriers that make them less excited about seeking mental health care. Although I do think I do see changes in terms of mental health stigma and how legit seeking mental health is becoming over time. As somebody who have seen kind of the evolution of mental health since Vietnam generation, I think that the current generations of veterans coming back from the wars in the Middle East are more open and less reluctant to seek mental health care, but especially there is a general notion that seeking care is perhaps maybe embarrassing, perhaps suggests some weakness, maybe delayed if needed, and time is an issue. I mean, timely intervention has shown and again is more effective as compared to intervention that was provided later, and I think that there is much more to do in order to. And I think somebody like Derek is doing a great job on kind of facilitating this message. There is more to do in terms of making mental health less stigmatic and making mental health care more available. One way I think that can really address this issue is providing mental health over the internet. And some of the veterans are really reluctant to go to psychiatric hospitals or to VA hospitals. By having remote care, which is most time showing that mental health care provided over the internet is more or less comparably effective. You can overcome some of the stigma that is associated with seeking mental health care, within a hospital or VA center.
Great. And this question also goes to you, Dr. Neria. Do you think first-line interventions found effective for civilians are equally effective for veterans? So, Dr. Neria, this question is for you.
Okay, sure.
Yeah.
Actually, so the question is whether treatments, evidence-based treatments that found to be effective or efficacious for civilians are also effective for veterans. I'm afraid I have kind of bad news about that. In fact, some of the first-line treatments for PTSD, such as prolonged exposure, PE, or CPT, have shown to be less effective for veterans, with higher rates of dropouts, with kind of poorer treatment outcomes as compared to civilians. And in fact, there is a need really to not only kind of repeat what we do for civilians when we treat veterans, but actually to look at veterans as a group of potential clients that need to be thought of in terms of specific culture and expectations, and what makes them involved and what makes them less involved. I'll give you one example. We recently completed a large study of equine-assisted treatment for veterans with PTSD, and patients, veterans in New York State, New York City, came to our center to be assessed and then transported to a very nice farm across the bridge in New Jersey, where they were engaged in treatment with horses. We manualized this treatment and we assessed outcomes as we do with any other treatment. And we have seen very low dropouts and relatively high success, suggesting that when you provide to veterans something that makes them engaged and less conflicted, they can do great. And I really encourage the community, the mental health community, to look for more innovative and more relevant treatment for veterans with mental health problems.
Thank you, Dr. Neria. I have one more question for you. And before I get to that, I just want to let all the participants know that as you type questions up, you can actually rank the questions that come in and do a thumbs up. And if there are many questions, it'll move it to the top. And if many people have the same question, please know that you can click on that thumbs up and it'll move to the top of the order. So thank you. So Dr. Neria, what should we do as scientists to improve mental health care for veterans and their family members?
So I touched upon it in the previous question, but basically we need to know the community very well. I think there is, and there is also a question that kind of popped out on the website about kind of gaps and how can we integrate the knowledge gap to practicing professional. I think that's really touching upon this point that if you bring clinicians to working with veterans, and those clinicians are not familiar with the veteran culture, with the veteran community, have not been served themselves, we are likely to see some, difficulties really to relate to what veterans need, to what veterans tell us. And I'll give you one example of that. One of the most interesting studies or set of studies conducted recently is about a phenomena named moral injury. Moral injury is about experiences that involved some moral conflicts, regrets, guilt that are based on experiences of either something wrong that I have done to other people, civilians, kids, or have seen wrong doings that I was not able to prevent, right? Veterans are very familiar with moral injury. Civilians much less. Veterans experience moral injury. Moral injury is very much related to PTSD, associated with PTSD, and with depression, and with suicidality. Most civilian clinicians are not familiar with moral injury, are not able really to treat it effectively. Some in the veterans mental health community are more familiar, and there is really a recent trend to attend to moral injury experiences and to address them in treatment. And this is one example of how can you really reach and communicate with what is really bothering the veteran. Another example, and perhaps I'll stop there, is sexual harassment and sexual trauma within the military that can experience both by women and men, actually. And there is sometimes a very unique forms for this sexual trauma. It involves power struggle. It involved all sorts of rituals, but some of it is more kind of consistent with what we see in the civilian society. In the military culture, there is really a great taboo on reporting on sexual trauma. Now, so many women, nurses, and men in the military have been experienced sexual trauma, and either not reporting about it or afraid to report about it. Addressing those things in treatment are highly, highly important.
Thank you, Dr. Neria. Dr. Rossiter, I'm going to ask you a series of questions now. Why do you feel military cultural competence is so important to providers in the civilian sector?
Great question. And I really think it's very important to have that cultural competence as we try to bridge that gap as providers between the provider and the veteran. It really is an important step to understanding that lived experience of military service and how that military service has had an impact on the physical and psychological health of our veterans and their family members. We often say that we don't know what we don't know, but we actually do know. We actually have done studies. There's several studies out there where providers are really telling us that they don't know how to care for veterans. And we know that if we don't have that cultural competency, we can actually do more harm than good with our veteran population. New York did their study on providers where 2.3% of providers met all 7 qualifications for cultural competency in caring for their veterans. There was another study done by Fredericks in Ohio where less than 50% of providers felt that they had the comfort level and knowledge to provide adequate care for our veteran population. So we know that our service members, veterans, and families live, work, play in a very unique and distinct culture. And then we also know that they have an occupational and cultural context that can have a real and lasting impact on their health. And if you don't understand that lived experience of the veteran, you don't ask about their military service, how are you going to be able to identify potential risks that are associated with military service or being part of a military family? Being able to gauge what conflict that service member was involved in, what era in time of service, what exposures they were exposed to during their military service. That's really how we work towards mitigating some of the comorbidities secondary to military service.
Thank you, Dr. Rossiter. Here's another question for you. Where could a provider go to find more information about military cultural competence and caring for veterans?
So fortunately, over the last several years, we have really, I think, built up a tool, a whole toolkit for providers. A couple places that I always recommend my nursing students, other providers go to look for guidance on how to care for veterans. Psych Armor website, the Psych Armor website. They have a wonderful website. It is sponsored by the Wounded Warrior Project. On that website, you can find multiple webinars on all aspects of veterans and their families. They talk about the visible and invisible wounds of war. They have a whole section on military service and military cultural competence. Also, there's a section on women veterans and their unique healthcare needs. I think probably the most important thing webinar is really the module that highlights the 15 things veterans want you to know. And that's really a great start if you're looking at trying to find out more about veterans. The Center for Deployment Psychology, which is affiliated with Uniformed Services University, they provide pretty much almost every week a webinar, once again highlighting different topics in regards to military and veteran health. They also have a course on their website about cultural competency. The United States Department of Veteran Affairs, they have a provider toolkit. And then the American Academy of Nursing, several years ago, they launched their Have You Ever Served campaign. And they have a downloadable pocket card, as does the Department of Veteran Affairs. They actually have a pocket card for providers as well.
That's great. Thank you, Dr. Rossiter. I'm going to pivot to a question that Sam asked in the chat. Are veterans able to trust clinicians that are not veterans themselves?
Is that for me? No.
Yeah, we'll go with Dr. Rossiter on that. Can you answer that one?
I think the most important thing you can do as a civilian provider with no, history in the military is just be an advocate. Listen to them. Ask the question. Like I said, the most important thing you can do is ask that veteran the question. You may not know all the answers, but as long as you provide a safe, atmosphere where that patient can talk to you, describe what's going on with them, and and advocate for them. Know who your resources are in the community. I think you can build a very positive relationship with that patient.
Great. Thank you. Another question, are there any tools out there that providers could use as part of their toolkit that could help them provide culturally competent care?
I think the two biggest ones for me, as I mentioned, at the United States Department of Veteran Affairs website, they actually have a downloadable pocket card. It's called the Military Health History Pocket Card for Health Professional Trainees. That's a great resource. It's a double-sided pocket card. Talks about questions to ask. It discusses patient and benefits and how you can bring that up with your patient. They go through all the different errors and conflicts and risks that are inherent during those conflicts that you might want to discuss with your veteran patient. As I mentioned, the American Academy of Nurses also has a pocket card. Once again, an excellent resource, provides prompts for questions that you can ask your veteran. And then in my later presentation today, I'll be talking about military connected children. And a team of myself and a team of other nurses and nurse practitioners, we developed a pocket card for military connected children. Once again, double-sided pocket card, talks about, how to ask questions of your military families and military connected kids. I think those are all really good tools to keep in your toolkit.
That's great. And I think coming up, you're going to share some of those tools in future presentation that you're doing after this session. Is that correct?
Yes, I know Dr. Rugen and I are going to both be talking about how to identify and care for veterans and their families.
Great, because that's great. Some questions have come up about those specific tools, so stay tuned for those tools.
I think
Dr. Ross.
We will highlight those tools in the next presentation.
All right, great. And Dr. Rossiter, what is the most important thing a provider can do to support their veteran patients?
I think the most important thing, like I said, is just really be an advocate. Educating yourself. I mean, this is probably one of the first steps, is educating yourself on your veteran population, who they are, what their experiences are, learn more about military cultural competence. Once again, asking the question, ask every single patient that walks through your door, have you ever served in the military? Or do you have a family member serving in the military? They may not be a veteran themselves, but they could be the parent of a veteran who's caring for their veteran child who was injured, in one of the war in Iraq or Afghanistan. It might be a veteran child, a military connected kid who might be experiencing, some of the issues associated with parental military service. I also think once you ask that question, it's really important to listen to what that veteran says to you or that veteran's family member says to you, because you might be the first person that ever asked that question. And, this is a great opportunity for them to let you know about what's going on with them. Incorporate what that veteran tells you into your history and your physical exam and your treatment plan. And then document, because now that we know that more and more veterans are being seen in the civilian sector, your documentation is going to be critically important as they take things back to the VA or they look for other resources or referrals in the community. No, you may not. So when you ask that question, it's a very scary question to ask, especially if you don't feel comfortable or you don't know a lot about veterans. But just because you don't know the answer doesn't mean you can't help. Make sure you know who those resources and referrals are in your community. So if something does come up that you're not familiar with or you don't know how to deal with, know who to send those veterans to. The VA is always a great option for our veteran population. And then, finally, just advocate. Be there as a support system, advocate, try and be proactive versus reactive.
Great. Here's another question for you. From a policy perspective, what would you advocate for in regards to veterans healthcare?
I think my three biggest areas right now from a policy perspective, obviously we know that there's a positive research out there. There's a lot of gaps. So from a policy perspective, advocating for more funding for veteran research, especially we've done a lot of research on veterans. We still have a long way to go, though. So research dollars for our veterans. But two big areas where we don't know a lot: military-connected children. We're just now starting to see that research come out. And the third area is military spouses. They have been a hidden and unidentified tier of that military family that I think we need to focus some efforts and research in regards to some of their needs. We know the stability of the military spouse really determines whether that active duty service member stays in the military and how well that family does, especially during deployments and relocations. So I think research money is number one. Number two, from a policy perspective, I'd really like to see an EMR identifier in all medical health records that prompts you to ask that question. You know, are you a veteran? Are you, or have you ever served in the military? Are you a veteran? You know, identifying their veteran status. And then from a practice perspective, really looking at incorporation of veteran competencies into patient assessment, treatments, referrals, into our nursing and provider education.
Thank you, Dr. Rossiter. I have a question from Kirsten, that has come in. How might the healthcare system of defense, the VA, and the civilian healthcare system help veterans in the reintegration process after military service ends?
Dr.
Whoever, and whoever feels most comfortable answering that one, Dr. Neria, do you want to try that question?
I'm not sure I know the answer. Okay.
I'll take a stab at that. Coming off, so I was active duty Army, and then transferred into the Air Force Reserve. I think one of the biggest things that I see is that gap in services after someone leaves the military and transitions to that civilian sector. Oftentimes, there's a significant gap between leaving active duty and bridging into the VA. I think really trying to integrate the VA and the active duty system would be helpful, because I think we know that time frame from when a veteran leaves the military healthcare system and is able to either apply and get services with either a civilian provider or at the VA. That gap is really where we start to see issues with our veteran population. The isolation, the lack of access to care. That's where I really think we are falling through the crack. So I think trying to bridge that time frame and shorten that time frame would be very helpful in that reintegration process.
Great. Thank you, Dr. Rossiter. Here's another question for you, specifically for Dr. Rossiter. Do you have recommendations on best and most current resources or tools available to assess and educate about cultural competence?
I think the tools that I mentioned, the VA Pocket Card, the Have You Ever Served campaign from the American Academy of Nursing, I think those are the two best tools out there to help us educate about competence. Once again, visiting some of the websites that I mentioned, like the Psych Armor and the Center for Deployment Psychology. They actually have, webinars as well as modules that you can go through to help build that cultural competence.
Great. So there's lots of questions about links to these tools, and I know that you're going to get to that in your next presentation, and there's some visuals there, so that'll help some of the attendees see what you're referring to. Here's another question. I'm sorry, how much do service members learn about the importance of good mental health while serving in the military? Who wants to tackle that one? Dr. Neria or Dr. Rossiter? Who feels more prepared for that one?
So I can try here. and perhaps Gil can chime in. I think the mental health have multiple aspects. Some of them are consistent with military culture. Resilience, coping, effective coping, peer support, cohesiveness, etc. So, but I do feel that kind of trauma-related problems are less spoken about, and with a much more kind of reluctance to address. And I wish there will be one day that the effect of combat trauma or sexual trauma will be legitimate exactly as other conditions, health conditions like diabetes or headaches or back pains or cardiovascular disease. I mean, there is something really very specific regarding how to keep mental health, how to address mental health problems that are becoming kind of contradicting military expectations of bravery and heroism and mastery, etc. And I do like to see a change in that, with much less reluctance really to give room to trauma-related problems, depression, etc. At the end of the day, we have about 25% of the veteran population who are consistently showing up with mental health problems that deserve attention, and we need to open up the discussion about them.
Thank you, Dr. Neria. I have another question on education from Tom Meyer. Given that we are playing catch up in bringing practicing providers up to speed, shouldn't we be playing get ahead by integrating this content into provider educational curricula? Dr. Rossiter, you want to take that one?
Sure, I'll take that one. I think that's a great question. And as I mentioned earlier, yes, I think that's one of the things from a policy perspective that we need to work on, increasing the education of our providers across educational programs. I know some of the work that we're doing with the American Academy of Nursing on our expert panel, our military and veteran health expert panel, is looking at integration of veteran health competencies across curriculum from a national level. That's one of the things that we're, many of us, that's a topic that's near and dear to our hearts on that expert panel. So we are, hoping that will come to fruition sometime in the near future, especially once again in regards to the Mission Act. Part of the Mission Act provided for allocation of funds to educate providers. So hopefully, moving forward, that will be part of our DNA education.
Absolutely. So at this point, just seeing if there's any new questions that have come in. And I'm just going to give it a few moments. All right. Well, I don't see any. Oh, actually, at the last moment, here's a question. How are spiritual needs assessed and addressed? Are there any specific spiritual assessment tools and/or interventions recommended for this population? Maybe Dr. Neria can answer that question about spiritual.
Perhaps partially. I do think religious belief, spirituality is really, natural kind of component of any given culture, and I think the military really has been doing a relatively good job with regard to giving place to spirituality and faith, um, but I'm not sure whether there is a sense within the community that more should be done, and in what way. I think, for example, the last time that I've been thinking about that is with regard to people who are lost, who are losing or lost, colleagues, peers, soldiers in the military through combat or through COVID, and the question whether there is a room really to a kind of experiencing grief in a way that kind of respect the context in which the loss was experienced. It's always important and should be encouraged. So I can't talk beyond that, but I think it's an important element in the mental health context.
Thank you, Dr. Nuria. I have another question from Kirsten. Stigma, resilience, warrior mindset. What is the role of peer support normalization regarding universal civilian reintegration experiences?
Yeah, so I spoke about a little bit about it before. I think this is really key to homecoming and discharge, from the military, and I think Gil spoke about it as well. I think there is a crucial point for a young person kind of leaving the military and either going back home or going back, or going to study elsewhere, in which the veteran really is about to lose a certain social network, and to hoping to replace it with a new network, friends, work, studies, etc. Luckily, social media and the internet as a whole is kind of mitigating this loss. Imagine, times where people really physically lost any contact with their peers in the military while transitioning to civilians' life. This is where suicidality is becoming more prevalent, depression, etc. So keeping intact with your own experiences, the culture, the military culture, I think is key to successful integration into the civilian community, rather than kind of a breakdown in this process. So I wish both DoD, VA, National Guard, will put more thought into how to really enable relationship and connection with people who are transitioning to civilian life, while leaving them enough, freedom to explore new opportunities, new friendships, new mentors, new peers. I think that's really important. Now, we are seeing, a good example is Columbia University. Columbia University has a great program, undergrad program for veterans that are coming as part of the GI Bill to study at Columbia. There are they form their own kind of virtual communities. They are in touch with each other. They take care of each other. I think those are really kind of some mechanisms that can, alleviate some of the problems while transitioning to the civilian community.
Thank you, Dr. Neria. I have a question here that's saying, if it's not obvious, are there any red flags healthcare providers should look out for to identify veteran patients? So we're looking for red flags.
Yeah. Again, I can start briefly on that. I think this is really what makes a clinician a good clinician, somebody who can identify kind of more hidden, more subtle, red flags, and from my experience and from the experience of the clinicians that I'm working with, and it's uncommon for a veteran to come and declare, openly, listen, I have a big problem, I need help, I feel that I'm deteriorating. Usually there is some more hidden, kind of more subtle kind of dialogue between the patient and the clinician. So when a patient is kind of silent for a long time during the sessions, where a patient is dropping out for treatment or skip out on meetings. When a patient is too angry, and when a patient is withdrawing into using or abusing drugs more frequently. So especially depression, doing suicide risk assessment is very, very important with any patient with mental health problems, especially depressed patients, trying to understand whether they have access to firearms, whether they have plans, whether they think about suicide very frequently. So there is a lot of, need to develop this, extra senses in order to capture risk, and it should be part of any good clinical training.
Thank you, Dr. Neria. And this will be our last question. And I do want to mention that we will be sending a follow-up email to everyone registered with a list of resources and links that have been mentioned in today's presentation. So you don't have to write them down. We will be following up with you. So with that, I'm going to ask this last question that has to do with spirituality and religion. So the military equates spirituality. Where did that question go? Okay, thank you. The military equates spirituality with religion. How do we support spirituality when not based on religion, which is important during reintegration into civilian life? So the question is about spirituality when it's not religion.
Not really my area of expertise, but I would say that probably in the same manner in which we support any of our patients from a spirituality perspective, once again, trying to be supportive, in that individual's beliefs or belief systems, and doing what we can do to support them as they transition out of the military and help them find those support systems in the civilian community or in a another peer-to-peer veteran support group in the community. Not sure if that really answers the question, but.
Okay, well, thank you, Drs. Neria and Rossiter. As a reminder to our audience, you can learn more about the speakers by visiting their bio page on the conference website. So with that, I am now pleased to welcome Dr. Catherine Rugen for our next presentation. Dr. Rugen is in the Office of Nursing Services in the Veterans Health Administration and is also the Director of Clinical Practice as well as an Associate Professor at the University of Illinois at Chicago. Dr. Rugen will join Dr. Rossiter for this panel as we learn how to identify and care for veterans and military families in private healthcare settings. Please welcome Drs. Rugen and Rossiter, and I believe Dr. Rossiter will kick things off.
All right, thank you very much. Once again, good morning, everyone. I'm happy to be here to present today on iServe 2, Meeting the Needs of Military Connected Children. So first, let's see if I can do my slides. Okay, I've mastered the technical portion of this, I guess. So first of all, my disclosures. I have no funding sources, no financial disclosures, no conflicts of interest, and the views expressed in this presentation are those of the authors and do not reflect the views, official policy, or position of the University of South Florida, the Department of Defense, or the United States government. The learning objectives for today's presentation include describing the military culture, military family life, the deployment cycle, and the impact on military-connected children. We'll also be appraising factors affecting risk, resilience, and health-seeking behaviors in military-connected children. And finally, we will construct approaches for healthcare providers to use the iServe 2 strategy to create a supportive environment for military families. Okay, since the onsets of the war in Iraq and Afghanistan in 2001, military personnel have experienced more than 3.3 million deployments. Operation Enduring Freedom, which is the war in the war in Afghanistan, is now the longest military engagement in history, lasting more than 19 years. Currently, approximately 1.3 million service members are serving on active duty, and another 815,000 are serving in the Reserve and National Guard. Roughly 39% of those serving on active duty have family responsibilities, meaning they have at least one child, and 41.5% of Reserve and National Guard members have. Over 1.8 million children have the distinction of being called a military-connected child, and they're young. As you can see on the slide, approximately 78% of active duty children are under the age of 11, and about 80% of Reserve and National Guard children are under the age of 15. In addition, there are 1.8 million children of veterans. And when I say that use the term veteran, I'm describing those who are separated before the 20-year retirement requirement for retirement, or they may have been medically retired secondary to an illness or an injury that occurred during their military service, or they could have retired after 20 plus years of military service. So upon leaving the military, these veterans will assimilate back into civilian life. And as a provider, you may not be aware of their veteran status or their military affiliation. I'm losing there we go. All right, and I would be remiss if I did not mention our Blue Star and Gold Star children. So our Blue Star children are the children who have a parent serving in combat. Our Blue Star children have experienced multiple deployments over the last 19 years. Some military-connected children have endured upwards of 10 or more deployments during their lifetime. We now have an entire generation of children whose parents could potentially have been at war. Many of our service members are returning to families with both the visible wounds of war, such as amputations and burns, and the invisible wounds of war, such as post-traumatic stress disorder, traumatic brain injury, and military sexual trauma. And the parents of service members, military spouses, and military connected children are taking on caregiver responsibilities and an increased burden of care while caring for their wounded warrior. And then sadly, there are about 15,000 children classified as Gold Star children. And Gold Star children are the children of service members who died while serving in combat. Can I have you advance my slides for me? Okay. There's such a delay on my phone. So it's important to distinguish between our active duty military families and our reserve and National Guard families as it pertains to their lived experience and the resources available to them. For our active duty service members, this is their full-time job, 24 hours a day, 7 days a week, 365 days a year. They live, work, and play in unique and distinct cultures, and we know that our military families have an occupational and cultural context that can have a real and life impact on their health. Our active duty service is in a constant state of readiness. They can be called to deploy anywhere, anytime, and sometimes within 24 hours or less. Those who serve speak a different language, even between the various services. For example, the place where you eat your meals can be referred to as the dining hall, the DFAC, the chow hall, the galley, depending on which branch of military service you serve in. We also use a lot of acronyms in the military, things like TDY, FTX, MTF, UCMJ, POV, FOB, and you can always pick out that military kid when their mom calls and you hear them say, Wilco, see you at 1700, Mom. That was always the telltale sign of a military kid. The military culture and lifestyle provides for many amazing opportunities and experiences, such as travel and working and living in diverse communities, countries, and cultures. Next slide. So when you hear the term military child, it can elicit many words to describe the positive effects of being part of a military family. They endure many deployments. As I mentioned, I have met with children whose parents have deployed anywhere from 2 to 12 times. In addition to deployments, they face short-term and long-term separations known as TADs or TDYs, essentially temporary duty assignments. And TDYs can last for a few days to several months at a time and are usually associated with a service member leaving to attend a school or training somewhere, to fill in at another base or military installation, or to serve in a foreign country on a humanitarian aid mission. They also move frequently or relocate, typically every 2 to 4 years, either in CONUS, which means within the continental United States, or OCONUS, which means outside of the continental United States to some overseas location. Because of this, military-connected children are less prone to risky behaviors or substance use. With every move, our military-connected children have the opportunity to reinvent themselves and quickly learn how to make new friends and adapt to new environments. On average, military children attend 6 to 9 different schools from kindergarten through 12th grade. Our military families tend to be financially stable, meaning that they're employed and they have a steady paycheck. Our active duty military families have access to numerous resources, support systems, and healthcare coverage. However, sometimes this can work against them because during constant moves and relocations, many of our military families experience disruptions in social support networks and established resources that can affect their continuity of care. Our military families do build close bonds with other military families living on or near their assigned military installation, and these individuals become their military family, often taking on many of the support roles in absence of the traditional extended family. Military families tend to have close bonds because the one constant in the many changes in their life are their parents and their siblings. And if you ask a military kid where they're from, most will tell you wherever their family is. Next slide. So conversely, the members of the Reserve and National Guard are citizen soldiers who live and work in civilian communities across the country. Since 9/11, the Reserve and National Guard forces have been deploying at higher rates due to the longevity of the current engagements overseas. This is this is especially true of our National Guardsmen, who historically their mission has been to provide military support in the state where they're serving during such things as natural disasters, civil unrest, and state emergencies. However, over the past decade, their mission has shifted somewhat, and now our National Guardsmen are supporting security interests nationally and internationally and are deploying overseas once again due to the longevity of the wars in Iraq and Afghanistan. Next slide. When the Reserve or National Guard parent is called up to active duty, the children suddenly become military. Children of Reserve and National Guard forces tend to remain geographically stable, but typically reside in communities that may lack the knowledge of the requirements and demands of military service. Our Reserve and National Guard members typically juggle two professions, as well as all the education, trainings, and certifications that go along with both of those jobs, their civilian job as well as their military job. And while they may live close to their assigned unit, others may travel long distances to their unit, which reduces the number of already limited services available to the military family, as well as support systems associated with military service. They may live in communities that lack the knowledge of military life. They may be the only family in their neighborhood or the only child in a classroom or school that has a parent serving in the military, which can lead to a lack of understanding and available support networks. Children of Reserve or National Guard families are not eligible to access the many services provided to the active duty members, such as health care, child care, recreational programs, and even when that reservist or National Guard member is called up to active duty, they may not be able to have access to some of the resources available to our active duty service members. And there may also be a shift in financial status. There could be an increase or a decrease depending on what job you're transitioning into when you get called up to active duty. So there could be an increase or decrease in family income, which could have a significant impact on their financial stability, as well as their health care benefits and access to care. Next slide. Fortunately, the term used to describe most military children is resilient. Military children bloom where they're planted, and that's why the dandelion is the official flower of the military child. Most military-connected kids have a process of adapting well in the face of adversity, trauma, tragedy, threats, and stress, and they typically bounce back without any issues. Next slide. However, risks do exist. After 19 years of war, military-connected children have been exposed to a large number of stressors and uncertainties that put them at a higher risk for physical, psychological, and behavioral health issues. The literature is just beginning to show that military-connected children are at a higher risk for abuse and neglect, substance use, and suicide when compared to non-military connected children, especially during the relocation and deployment cycle. They experience stress and depression related to parental deployment or parental post-deployment physical or psychological injuries. A significant number of military children have experienced the death of a parent, and military-connected children experience stressors that may be reflected in changes of behavior, academic issues secondary to emotional distress related to parental stressors, or somatic symptoms such as depression and anxiety that can lead to changes in appetite, disrupted sleep patterns, and impaired immune responses that can impact their overall physical and psychological health. These children may show up in your office or your clinic with many of the symptoms that I just mentioned. And as a provider, if you're not aware of this patient's connection to the military, you may not include parental military service in your assessment, differential diagnoses, or your treatment plan. Next slide. So why is this important? This really becomes significant in the clinical setting because currently, right now, about 75% of active duty military children and 100% of Reserve, National Guard, and the children of veterans are seen in the civilian setting by providers who may be unaware of their military connection. In the very near future, we may see the shift from the active duty side change. The Defense Health Agency is discussing shifting their military healthcare mission to strictly focus on the active duty service members. So if that does roll out, we will be seeing 100% of even our active duty spouses and children being seen in the civilian sector because they will no longer have health care services on military installations. It's important to note that most military families do not self-identify as spouses or children of service members, but there may be clues. On the active duty side, providers may be aware of military status based on the use of TRICARE insurance. All of our active duty service members have TRICARE as well as their families. But for our Reserve, National Guard, and veteran children, there may be no distinction between them and any other patient in the office or clinic. So this is where continuity of care, and we also know that continuity of care becomes an issue as our military families move frequently. Knowledge of military status is critically important in order to address issues quickly and provide resources and referrals. Knowing where the military family is in the deployment cycle and relocation cycle is important so providers can be proactive in establishing continuity of care. And some of the studies that I mentioned in the first section about lack of knowledge of providers about veteran health, even though there has not been any real studies about lack of knowledge on the pediatric side, we know that probably those studies would correlate with knowledge of pediatric in the pediatric population. Next slide. So while military-connected children live with a sense of patriotism and respect for the role that their parent or parents play in providing for the safety and security of our country, there are many military families who bear a significant burden that does impact their physical, psychological, and behavioral health. Military service has been described as a family business. Approximately 80% of those who recently enlisted in the armed forces stated that they had at least one family member who has served, and more than 25% stated that they had a parent who was either serving in the military or had served in the past. The inability to adequately support the physical, psychological, and behavioral health of military-connected children places them at risk for health issues that could preclude them from military service should they choose to serve when they turn 18 years old. Additionally, the perception of lack of consideration for military families may disenfranchise the military-connected child from continuing the legacy of family service in the military. And this coupled with a report that came out several years ago where over 120 retired generals and admirals were concerned that more than 70% of young adults in the general population between the ages of 17 and 24 who were ineligible for military service due to obesity, physical and psychological health issues, and incarceration and several other items. This really places the nation at a deficit in meeting recruiting quotas and could potentially impact the national security of our country. So this is why one of the reasons why it is so critically important that we identify and provide competent care for this population. Next slide. So this leads to one of the tools that I had mentioned in the earlier segment about how can we provide culturally competent care to our pediatric population. So the I Serve 2 pocket card was developed about 3 or 4 years ago, just started rolling out over the past couple of years. It was developed by a group of nurse practitioners and nurses, PhD research nurses, who had experience in the clinical setting, the research arena. We were all retired or military or had served, and we also were either military children ourselves or parents of military. And the pocket card, it's a double-sided pocket card, and it really aims to raise awareness of the unique health and educational needs of children whose parents serve in the military, both on active duty or in the reserves. When you look at the pocket card, on the front side, we have the call to action, really acknowledging the fact that military children make a tremendous sacrifices in support of their parents' military service. And then when you look down at the lower left-hand side, that's the prompt for the provider to ask all patients or their parents, depending on the age of the child, who you would address, whether it's the patient or the parent. Do you have a parent, sibling, or other family member who has served or is currently serving in the military? And if that parent or patient answers no, then you move on with your physical exam and your what's going on with the patient. However, if that patient does answer yes, there are several questions you might want to ask. The first is the parent or family member active duty? Are they a reservist, National Guard, or veteran? Because this will give you a good idea of what resources might be available to that family or that child. You also want to ask if the parent has ever deployed, and if so, where or when. Once again, this can give you cues to what type of comorbidities that child might have, or what they might be experiencing in regards to that parent's military service. I think back to like our Vietnam veterans who, with exposure to Agent Orange, we were seeing not only in the children of Vietnam veterans, but the grandchildren of Vietnam veterans with certain types of pediatric cancers, leukemias. So knowing that veteran status would be critically important. You also want to know where that family is in regards to the deployment cycle and the relocation cycle. Once again, that can help you provide supports needed to make that transition smooth for the family. On the right-hand side at the top, we have an overview of the deployment cycle. I'm not going to, due to time, I'm not going to go into each specifics of each phase, but really it provides you with a basic overview and potential risks that might be associated with each phase of the deployment cycle. We also provide resources for our family members as well as providers, everything from Blue Star Families to Military One Source to the Military Child Education Coalition. These are great resources, as I said, for the provider to learn more about the military family, as well as resources that that provider can give to the military family to help with questions in regards to education, what support networks might be available in the community, as well as employment for spouses. Some of them even have chats where military-connected kids can engage with other military-connected children. And then on side 2 of the pocket card, next slide. Oh, I'm sorry. Yeah, next, thank you. On side 2, we provide you with the iCare support strategy for military-connected children. And that's an acronym. iCare is the acronym for identify, so know who your military children are in your community and your practice. Correlate what's going on with that military child based on developmental stage, and address healthcare concerns in the context of that individual child. You want to ask how that child's coping. You want to really, this will help you be proactive versus reactive. Think about what's going on with that child. Conduct your vulnerability and safety assessments. Readying resources, looking at resources in the home, the school, and the community to help that parent engage partnerships that can help build resilience with that child. And then you always want to encourage and educate your parents on prevention strategies. Once again, building resilience for these kids. Knowledge is definitely power, so building those strong families and promoting healthy problem solving. On the right side of the pocket card are questions that could be asked of parents or their military child during well child or acute care visits, things that might cue you into or clue you into what's going on with that child. And then we also provide you with your vulnerability and risk assessments. Really looking for potential risk with abuse or neglect with these children. So some questions that can ask you and guide you in asking those important questions. Next slide. So I really think this slide really sums up what life as a military-connected child is like. Parental military service can have such a profound impact on them. While we're just now beginning to see research regarding military-connected children, many questions still persist in the research, policy, and practice arena. And as APRNs and nurses on the front lines of veteran healthcare, we are really in a unique position to address these questions. And that's all I have. And once again, I want to thank the Jonas Philanthropies and the New York State Health Foundation for the opportunity to present today and for their continued commitment to those who have served in harm's way. And thank you for your patience that's much needed and your support of our military and advocacy.
And thank you, Dr. Rossiter. We just have time for, I believe, one question that came in. And this is for you. Why is it that they do not have access as NG to similar services or resources? And NG, is that non-governmental?
I think they're talking about National Guard.
Oh, National Guard. Okay.
Our National Guard So our National Guard and Reservists, do not have the wide range of services that the active duty side has. First of all, there's not enough services available to incorporate the Reserve and National Guard into those services. Once they become called to active duty, they do gain more services. So on the Reserve National Guard side, you can go to the commissary. There's certain things that you do have access to, the BX or the PX, the commissary, but there's just not enough healthcare resources on military installations to be able to provide those services to the Reserve and National Guard. When you think about child care, once again, not enough resources to include the non-active duty service member in those.
Thank you, Dr. Rossiter. All right. Well, thank you so much for your presentation and your wisdom. And at this point, we're going to turn it on over to Dr. Rugen.
Hi, everyone. Kathy Rugen from the Veterans Health Administration, the Office of Nursing Services, where I serve as the Associate Director for Clinical Practice. I also serve as a primary care provider in a care clinic in the Chicago area and am Associate Professor at the University of Illinois at Chicago. So pleased to be here with you today. And thank you to the Jonas Foundation for the invitation to present here today. Okay, let's get started. So my learning objectives for today are that you will be able to ask appropriate questions regarding their military service, identify potential exposure concerns, and also list VHA resources that are available. So I always like to start off talking about the Department of Veterans Affairs and the Veterans Health Administration, because I think people get that confused. So the VA, big VA, is the second largest budget of all the cabinet departments. Secretary Robert Wilkie is the secretary for the VA. Sorry, I'm just learning how to use this, my remote here. So the VA is actually divided into three separate departments: the Veterans Health Administration, the Veterans Benefits Administration, and the National Cemetery Administration. So three separate entities. And I think when people read things about benefits, they get that confused with healthcare. So they all are very separate. So the VHA, the Veterans Health Administration, is the largest integrated healthcare system in the United States. And we have at least 1,200 healthcare facilities, and that seems to be growing every day. And that includes 170 VA medical centers, plus over outpatient clinics. And we have clinics in Puerto Rico. We have actually a medical center in Puerto Rico. We have clinics in the and you can see the nation divided up into various integrated healthcare systems. So just to give you some numbers, in 2018, more than 9 million veterans are enrolled in VHA healthcare. That's not even half of all veterans. So not even half of veterans are enrolled to receive care at the VA. So that's very important for those of you in the private sector, even before the Mission Act came into place. There are 340,000 plus VA employees. We have just 1 month, this is from last year, some statistics, over 5 million appointments in various clinics across the VA system in the month of May, 4.7 in the month of June. Very different this year, obviously, due to the pandemic. The VHA is the largest education and training system for the healthcare professions trainees. Over 120,000 healthcare trainees from many different professions, 50 different professions training. about percent of all physicians have some training within the VA system. The VA is the largest employer of nursing. We have about 105 various nursing personnel, and this includes RNs, LPNs, LVNs, nursing assistants, RNAs, nurse practitioners, clinical nurse specialists. We do have several nurse midwives also in the VA. Have those listed out there. You can see those. And recently, we've had an organizational structure where our chief nursing officer, Dr. Beth Taylor, also serves as the assistant undersecretary for health. So nursing's really moved up and very important within our system. Okay, so I'm going to now transition into taking our objective here today is taking a military history. And this content is on the Office of Academic Affiliations Military History Taking card. It's a trifold card. I included that in my handout, so please refer to that. I'm going to start with just some kind of general questions that you would ask, and then we'll get into the exposures. So in military history taking, you ask what branch of the military did you serve, when and where did you do while you were serving? How has your military service affected you? Did you see combat enemy fire, any casualties? Were you wounded, injured, or hospitalized? Were you a prisoner of war? Okay, and then now let's get into some specifics that are commonplace that we see in our veteran population. So in post-traumatic stress disorder, about anywhere from 11 to 20% of those who were in the Operations Iraqi Freedom or Enduring Freedom, OEF, OIF, so that's Afghanistan and Iraq, about up to 20% of those vets have been diagnosed with PTSD. If we look at the Gulf War veterans, about 12% of those who participated in Desert Storm had PTSD. And then looking at the Vietnamans, anywhere from 15 to 30% of those individuals have had been diagnosed with PTSD, and it's sometime in the lifetime. It's not always immediate. I've had a patient recently, of Korean veteran, and just some life-changing event really set off his PTSD, in his 80s, long after his service. So some questions to ask a veteran patient about traumatic stress is, have you had nightmares or about things that you experienced in service or thought about when you didn't want to? Have you tried hard not to think about it or went out of your way to avoid situations that reminded you of it? Do you feel constantly on guard, watchful, easily startled? Do you feel numb or detached from others or activities or your surroundings? Military sexual trauma is other common diagnosis in our veteran population. Some questions that can be asked to those veterans are, did you receive any uninvited or unwanted sexual attention, such as touching, pressure for sexual favors, or sexual remarks? Did anyone ever use force or threat or a threat of force to have sexual contact with you or against your will? And did you report any incident while you were in the military? Just some statistics here. About 23% of women veterans reported sexual assault during their military service, and about 55% of women and 30% of men have experienced sexual harassment while in the military. So it is quite present. Traumatic brain injury, another significant thing we see in our veteran population. And due to really improved diagnostics and increased vigilance, there are now more accurate statistics about military TBI rates. Okay. It's almost 500,000 veterans have been diagnosed with TBI for those who served between 2000 and 2019. And really conditions stemming from TBI, headache, irritability, sleep disorders, memory problems, slower thinking, and depression. The majority of people who do have TBIs are really classified as having mild TBI. But certainly these can affect things like long-term mental health and physical health problems, and it can impair veterans' employments, family relationships, and reintegration to the home and community. So some questions to ask are, did you experience heavy artillery fire? Were you vehicular or aircraft accident, any explosives, the IEDs, or fragments or bullet wounds above the shoulder area? Did you have any loss of consciousness, loss of memory, seeing stars, or being temporarily disoriented, or diagnosed with concussion or head injury? Sorry, my phone keeps turning off to advance my slides. Okay, so veterans in suicide, this is, very publicized in the, everyday literature and in newspapers and magazines about the issues of veteran and suicide. And the number of veteran suicides exceeded 6,000 each year from 2008 to 2017. Also, the average number of suicides in the general U.S. population has increased, but so has those numbers increased for the veteran population. We can see 15.9 veteran suicides in 2005, and most recent statistics, 16.8 in 2017. And the suicide rate for veterans is 1.5 times higher than non-veteran adults after adjusting for population differences in age and sex. Firearms are the most common method of suicide in 70% of male veterans. Very important to ask about a gun in a home, and if the gun is secured and safety locks, etc. And 43% of female veterans committed suicide in 2017. Okay. Suicide risk. So some things that we'd want to look about, and was covered a little bit previously, but there's certain observable cues that should prompt you to be alert for possible suicidal ideations. Things like shame, humiliation, irritable thinking, paranoia, agitation, anxiety, insomnia, irritability, depression, feeling trapped, like there's no way out, life isn't worth living, no purpose of life, they feel like they're a failure. They have profound social withdrawal, neglecting personal welfare, their personal hygiene, deteriorating their experience, feeling a sense of hopelessness and depression. This is very important for us in the VA to assess for this. We assess for suicidal risk every encounter with the patient, and that is documented. Now let's get into some exposure concerns. And when we talk about exposures, we can mean chemical, like pollution or solvents, biological, and such as infectious diseases, physical, such as noise, radiation, heat, cold, blast explosions. And there's some initial questions to veterans is, what were you exposed to? What precautions were taken? Was there avoidance? Did you use PPE? Did you have any treatment for any exposures while you were serving? How were you exposed? Was it inhaled or on your skin or swallowed? And how concerned are you about the exposure? Okay, where and when were you exposed? and then who else may have been infected, like our previous presenter talked about, the family. Okay, so now I'm gonna, oops, I'm sorry, my phone turned off. So, okay, here we go. So now we're going to talk about a long list of various exposures, and you're seeing the patient, the veteran. These are some things that you should start thinking about when you have identified where they have served, and asking kind of some of these simple background questions. So first, we want to think about any radiation or nuclear weapon exposure. So these would be common in our World War II veterans, and there are them still around. I have about 3 95-year-olds who served in World War II. So there's also POWs in Japan, certainly were exposed to radiation. Those in Korea, Bosnia, the Gulf War, and Afghanistan. And certainly there's a high risk for cancer in people exposed to radiation and nuclear weapons. Agent Orange. Agent Orange has been mentioned previously. Agent Orange is a defoliant chemical. It was used mostly in the Vietnam War to clear out vegetation for military operations. Also used in those exposed to Agent Orange have a high risk for cancer, lung and prostate specifically, type 2 diabetes, ischemic heart disease, soft tissue sarcoma, peripheral neuropathies, and then we see spina bifida is a common problem in children of veterans, and as Dr. Rossiter mentioned, also we see now issues from these exposures in the grandchildren of veterans. So, very important to identify these exposures. Camp Lejeune is a Marine training base in Jacksonville, North Carolina. It's on the coast of North Carolina, where there was amphibious water training for those Marines. And during January of 1957 to December of 1987, veterans and families who lived in Camp Lejeune possibly exposed to chemical contaminants in the underground water in the wells. And this is a cause for cancer. And you can see a long list of various cancers there. Also infertility, miscarriages, renal, liver issues too. So again, important to ask, not only our veterans who had served overseas, but those who are on military training bases, maybe didn't see combat, were on training bases in the United States. So it's important to get that full history. Certainly exposures to hepatitis C and HIV, this battlefield exposure to blood and human fluids. Also the group use of needles, razors, toothbrushes can certainly transmit both hepatitis C and HIV. We see this a lot in our veteran population from the Vietnam era. Okay. Open burn pits. And these are just open pits where they burn waste product from chemicals, paints, human waste, medical waste, metals such as aluminum cans, munitions, unexploded ordnances, petroleum lubricants, and we could just think of the pollutants that come from that. Open air pits were very common in Vietnam, Iraq, and in Afghanistan, and certainly high risk for respiratory exposures and some cancers like leukemia. Especially during OEF, OIF, there are a lot of concerns about biologic agents being used. So our veterans, and were given immunizations on a lot of things. Like there was a big anthrax scare, also botulism that could have been possibly used, smallpox, malaria, typhoid. So they have received a lot of different immunizations, and they're still questionable. Is there long-term side effects from the anthrax vaccine? There were questions whether that led to some issues, long-term fatigue like symptoms that have really been classified as kind of Gulf War syndrome, which I'll talk about shortly. Infectious disease exposure could be commonplace depending on where the service took place, from malaria to Wales virus and a whole different things listed out there. Also, there's temperature-related injuries in the World War II. In the Korean War, it was extreme cold. Also, in the OEF and OIF, there were also exposures to extreme cold. And extreme cold can cause certainly changes in skin and nails and muscle, and skin cancers can occur in areas of frostbite. There's neurological and vascular injuries like Raynaud's phenomenon. And then the heat exposures in the deserts of Iraq and Afghanistan can lead to heat stroke, heat exhaustion, sunburn from heat injuries during their military service, may be more susceptible to heat, and then other serious injuries from that in the future. Occupational hazards are wide and varied from whatever their job would be. So that's important to find out, what role did you play and what was your duties while you were in service. Exposures could be to asbestos, various solvents, lead, you've already talked, PCBs, the noise and vibration, especially if they're in a combat area, chemical agents that are used for coating various military objects certainly could also be a hazardous exposure. And then Gulf War syndrome, which I mentioned briefly. It's a syndrome. It's widely used term to refer to really illnesses occurring in veterans that served in the Gulf War, and the symptoms are really somewhat subjective and vague. So it's able to diagnose these patients. So it could be from anywhere from fatigue, just general musculoskeletal pain, cognitive problems, skin rashes, diarrhea. Those are common symptoms and complaints. And possible causes of Gulf War syndrome, just, chemical warfare that they maybe knew that they were being exposed to, particularly though nerve gas, and our veterans did receive this medication, pyridostigmine bromide, which is given as a preventive measure against the nerve gases. Certainly psychological factors and PTSD that we talked about and how commonplace it is could be a cause. And certainly the chemical agents that we talked about, those burn pits, other pesticides. I'm sorry, I went ahead there. And the smoke from iron from oil wells, if you recall back in the Gulf War, and the oil fields and all of the fires that the veterans were exposed to, the pesticides, depleted uranium, and exposure to a wide variety of things. So some common diagnoses that we see are for people with Gulf War syndrome are fibromyalgia, chronic fatigue syndrome, chronic a wide variety of GI issues, cognitive impairment, we see high rates of brain and testicular cancers and neurodegenerative diseases like ALS and MS. Okay. So there is the VA has an health registry, and this is for veterans who feel like they have been exposed, and there's more information there, and veterans can come in and you can refer them to the VA, and they can, have a workup specifically for exposures in a wide variety of exposures that you see listed there. And then I've put the website there for you too. But I would really just want to end here by saying that we really would like you to use the card on a military health taking that's from our Office of Academic Affiliations. I think that would be very helpful if this is new content for you to talk with our veterans. Okay, well, I'm done now, and I see that there's questions come back in, and I turn this over to Dr. Ferrara. Thank you.
Thank you, Dr. Rugen. All right, so we have lots of questions. We're gonna keep on schedule, and we're gonna take 5 minutes to answer questions. So we'll do some rapid fire. Dr. Rossiter, for AD children, one of the slides said they were less prone to risky behaviors, but a later slide it denoted they showed more substance use. Please clarify.
A great question. Yes, that can be a little bit confusing. Typically, the active duty child, as long as everything's going well in their life and they're adapting and their resilience is good to go, most of these children are less prone to any type of risky behavior, such as substance abuse, sexual activity, etc. However, where this becomes an issue is potentially during the deployment cycle or the relocation cycle, during times when these children may not be getting the support that they need, or having difficulties transitioning through those difficult times. So they would be at that point in time more prone.
Great.
That clarifies.
Thank you, Dr. Rossiter. We'll go to this next question for Dr. Rugen. What can we do for patients who may be part of military families and experiencing some of those illnesses you mentioned?
Oh, hi, thank
Well, I think Dr. Rugen might be frozen, which is the joy of a virtual conference. So with that, I'm gonna ask Dr. Rossiter, is there a PDF of the iServe 2 Pocket Card available for download? Seems like a great resource. This is from Deb.
I'm happy to share that with the Jonas Philanthropies. I'm not sure if we can provide a way for them to download that. Dr. Ferrer, is that a possibility?
Yeah, so after we're finished, we conclude, we'll be sending out an email to everyone with the links of resources that we could share.
Okay. Yeah, I'm happy to share it. It has been published a couple of times in the NAPNAP journal and the AAMP journal, so it is available there. But I'm happy to share it as an additional resource.
Great. So stay tuned for a follow-up email after the conference, and we will get that resource out to everyone.
Stephen, I'm back. Can you hear me?
Yes. Yes, I can.
After all that, I got cut off.
It's all good. We're good.
Okay.
So I think the question, let's see. Dr. Rugen, what can we do for patients who may be part of military families and experiencing some of these illnesses you mentioned?
Yeah. Well, certainly the veteran would need to go to the VA and, along with their family, and tell them that they have the symptoms. In the VA, we treat only the veteran. We only at a few sites do we have that are with the DoD that we partner have them. Then they're only in a few locations, but certainly I would bring forth the issues that the family members are having, certainly the medical issues. And certainly go to that website I provided about exposure-related health issues.
Thank you. I have a question here from Tom Meyer, and it's a great question. And this presentation has been certainly enlightening, because when we talk about military, there are so many divisions within. So do special operators such as special forces and SEALs and their families have unique lived experiences that result in special or amplified assessment needs?
I'm going to give that one to Alicia. I do not have that military experience.
Okay.
I think in regards to this question, I do believe that they might have additional concerns. Obviously, our special forces, they live in a very high operational tempo, op-tempo lifestyle where there's multiple deployments. Oftentimes, these individuals are responding in 10 to 12 hours for a national security issue that may have come up. So oftentimes, these families might have unique situations where they don't have time to prepare for a parental deployment. I didn't have time in my presentation to talk about the deployment cycle, but when you think about pre-deployment for most of our service members, that's anywhere from like a 3 to 4 month time frame where the family kind of starts to transition into like a service member parent leaving. Some of our high deployable units, oftentimes these families don't have that time frame. So yes, that could increase that could increase their needs and services based on the fact that they may be struggling having a parent coming home and leaving multiple times without adequate preparation. So I do believe that oftentimes they need a little bit more TLC and really being cognizant of that lived experience of that family situation.
Thank you, Dr. Rossiter. That really does it for our question and answer period. And we know that there have been many questions that have come in that we have not been able to get to. But what we're going to do afterwards is we'll list the questions and answers afterwards if we were not able to get to those questions during the live session. We've had such an overwhelming response and engaged attendees. So we thank you both, Drs. Rugen and Rossiter, for your insightful expertise. At this time, we will take a 5-minute stretch break. We have outlined some reminders for the conference in the following slideshow. And watch that slide counter for when we will resume the presentations after the break. And we will be led by my colleague, Dr. Althea Hicks.